most of the delegates have left, and I will not take too much long. I will show only 3 cases of post-osteomyelitis, non-union, 2 of tibia and 1 of humerus. The non-union in post-osteomyelitic fractures is mainly because of 3 reasons. One, the patients are present, many times the patients present late. And in many patients you find history of treatment by bone setter, and then after 15-20 days the patient present with subacute osteomyelitis. In those cases there are more chances of pathological fracture. Sometimes the organisms are so virulent that before the defense mechanisms of body comes into play, there is destruction of the bone, and that leads to non-union of the pathological fracture in osteomyelitis. And another important factor is the early removal of sequestrum. Many times when the patient presents in subacute stage and involucrum is just about to form, if that stage you enter surgically and remove the sequestrum, that patient is likely to end up with a pathological fracture and a non-union. Case 1 is a case of osteomyelitis of tibia. It was a male 3-year-old patient who presented 1 year after his index surgery. He had no active infection. The non-union was in the upper 1/3 of tibia, and the bone ends were atrophic. There was deformity also, and the limb, if you have noticed, the limb compared to the normal limb, the limb was already lengthened. So we decided to treat this patient with an Elizar ring fixator, and these are his initial X-rays. On the left side, initially the atrophic bone ends were excised and a gap was created, and it was compensated by distal corticotomy and segment transport. Once the bone ends came together, there was a deformity which was corrected with a hinge, and the patient remained in frame for 6.5 months, after which this frame was removed when the fracture showed signs of it. He was also put in a splint post-operatively because the bone was quite thin. And these are his follow-up X-rays. At 1.5 years, the bone is significantly remodeled, and at 2 years, it is almost like normal with good medullary cavity. So, this is the first case. The second case is a patient, she was a 5-year-old female child who was treated conservatively for osteomyelitis with only antibiotics, and she presented after 6 months with an ununited fracture in the middle of the tibia with intact fibula, but there is some evidence of healing response is seen, and adjacent joints were normal, and fibula was also intact, and there was no active infection. So in this case also, we opted for an ring fixator, whereas the only distraction principle was applied, and the non-union site was restricted by about 3 or 4 millimeters, which is seen in the second slide. At 6 weeks already the fracture had started healing. At 6 months the fracture had healed to such an extent that the frame was removed. And the last right-sided image shows the fracture remodeling and complete healing. This is 8 years follow-up. Third one is a very interesting case. This was a case of non-union. The patient had, she was a 16-year-old female. She presented with a gap non-union of humerus following osteomyelitis and septic arthritis of the shoulder, which was treated by multiple surgeons in the childhood. This is when she presented. I showed the X-ray. The plan was to do a vascularized fibula because she had already undergone free fibular graft. So this was the plan. This is why the arthrogram was done. And in arthrogram, you see that it is a well vascularized limb. But the most remarkable thing was of K-wire. The piece of K-wire is lodged just at the bifurcation of the brachial artery. So during surgery, that was also removed. These are her initial X-rays. Initially, she presented with swelling when she was 1 year old. These are her old X-rays. She was treated somewhere else. You can see in second slide that multiple K-wires were possibly put for the proximal separation of the upper end of humerus. Then she ended up with a gap non-union of the pathological fracture, which is seen in the next slide. Then she underwent fibular grafting. It was a free fibular graft and fixed with K-wire, which failed. And PCA wires broke and one of them pieces reached that brachial artery. We did vascular graft, free vascular graft along with, we took help of a microvascular surgeon who did free fibular graft, vascularized fibular graft, and these are an initial X-rays. An anatomical plate was put in a non-anatomical bone, so the fixation does not look very attractive. So additionally, the patient was also given a brace for 3 months. These are the initial X-rays. This is at 6 weeks, and as Ramesh bhai showed in his previous talk, these vascularized fibula really take very short time to heal. So after 3 months, it has already started healing. These are her 1 year follow-ups, and this is her functional result at the end of 2 years. So these are the 3 cases to show that though the non-unions look little formidable, usually with good planning and good technique, they can be treated successfully. Thank you.